have a roundtable on university training, how to integrate local knowledge in university curricula.
I will start with some personal experiences. I'm going to be very concrete right away. So I'm in residency in pediatrics at the University of McGill. And within our residency, we have one training month that we have to do in social pediatrics. Now, how does it work? Well, for this internship, there is a clinical part where we go to multicultural clinics. We also go to a First Nation clinics with Métis and Inuit. We can also go directly to Dr. Julien's clinic. So that really allowed me to see different phases, whether it's ER, whether it's pediatric units, intensive care units. And at the Dr. Julien's clinic, through my experience, I was really excited to see the team, the way that families and children are being approached. I think there is really an atmosphere that you know, literally you fall in love with the families, with the child, what they do. You really feel like you want to get involved. And also at community organization level, there is something very important and an important role to play. So I think all students should actually go through this experience. So I was in a way, I was in a bus. I was working on the prevention of problems and crimes, and we try to do a prevention at night. For instance, for sexually transmitted disease, we give some condoms and information, and also for substance or addiction, we also give some information on that. And then this was one part, and there was another part, and I won't be able to mention all of them, but also with this program called the Children of Hope, Les Enfants d'Espoir. So those are families from different backgrounds, different economic backgrounds as well, who will gather with their babies, and they're going to share with an educator what they experience with the children and how you can stimulate your children. And it was a beautiful experience at the Dietetic Dispensary of Montreal, when I saw also I had a session on breastfeeding. So as a resident in pediatrics, I never had any experience with breastfeeding, and it's so important. So it was really a very practical and pragmatic approach on the advantages of breastfeeding. I also went to see an organization that helps a younger mother. It was really a very complete and very diverse experience, and I believe every student should be able to participate to this type of training course.
I enjoyed your perspectives from the resident perspective of a social pediatric program, and I want to go here from this conference to go back to my University of Ottawa Department of Pediatrics and implement a nascent social pediatric program, because we don't have one. That's something working as the director of the Child and Youth Protection Program at the University of Ottawa. I implemented 15 years ago now, a mandated, it's compulsory, 1 month elective for second year pediatric residents in the Child Protection Program. And I think from the comments that I've made with some of you here, you know that I'm not just about protection of children and youth from maltreatment, but indeed protection of their rights and indeed promotion of the human rights of children. So that perspective is much more incorporated into this child protection rotation curriculum that the residents come through. There's also a 2-week elective that I opened up for medical students, and I see a lot of dreadful cases, as we all do. The people in this room know the kind of sad, difficult situations we're going through, but the energy that I get from the residents and the excitement, and you're nodding, you transmitted that, and the medical students, they're excited about this area. And it gives me an excitement, it gives me hope, and working with a group, discussing. I always like to have students with me for debriefing for a lot of the discussions that come out of these cases. So just to say that my perspectives evolve certainly, and I'm hoping to institute, and I want to know from other people on the panel also, what is social pediatrics, what is social community pediatrics, because I need the name, because I have to get I have to get this valued within my hospital. I am actually working in the community because I go to the police and I go to the CES and I go to the schools. I'm doing all that, but basically I'm paid by the hospital, the provincial system. But whatever that is, I need to go with an argument for value. I know the value, and I don't need any evidence base for that. We should say we're dealing with families and kids, and that should be quite enough. But we need to know this stuff works, and I think I would like to open a space which to say that to my chiefs that we don't need to go as pediatricians when we see a problem family as exists at the moment, I feel, to hot foot, to pick up the phone, and it's the Children's Aid Society. And I think anyone who works with child welfare system, those people are doing their best, but they've got caseloads coming out of their ears. They're in the investigation mode. They have to close the case by 1 month. And where are the supports for the families? And social pediatrics opens up a space there that is poorly needed. We all need that space to be supportive with families. And it's not just the criminalisation arm of the child welfare provincial legislation, but we should be using the overarching, much more child and family-friendly legislation of the UN Convention. I'll just say 2 more pieces because we have a few more speakers, but I'm involved in Curricula in 2 other projects that I can talk about. One is, and you can go to the website, it's called CredPro, Child's Rights Education for Professionals. I'm working with an international group based from the International Institute of Child Rights and Development based in BC in Victoria, and we are committed, and there are some curriculum online that you can use, open access. We already have one for pediatricians, early childhood development, school psychologists, and we're working on one for justice, education, all sectors. And you're welcome to join any of those. They're open-ended, and what we're doing is developing modular curricula, 6 to 7 modules, generic curricula that you can use in your own sectors across the world. You know, it's going to be different in Nigeria from Australia and from any other place. The other piece, and I think I'll save this piece for a little more because it's relevant to what we're talking about here, community and social pediatrics. I'm involved with Jeff Goldhagen's group in the US, developing the first American Academy of Pediatrics endorsed community and societal pediatrics, not social. So I'll just stop there and join the discussions.
Mais ce que je veux faire, surtout avec vous cet après-midi.
What I want to do right now this afternoon is, for the last few days, I'm really thinking a great deal. The question that was put for this roundtable is how can we really integrate local knowledge, which is developed in the field of social pediatrics, and how can we include them in our university courses? And it's Friday afternoon, and we're a little bit tired, so I think I was going to tell you a story that was really the trigger for me. A trigger that really led me to integrate the local know-how in the social pediatric centers in my teachings at the university. I'm just going to say a few words. Well, this experience I'm not going to describe right away, but I will have a chance, I hope, to say more about this. And I'm also, I'm a professor by choice, so I go directly to intervention environment, and I go around different environments. And at one point I was visiting a training course one day that was a rather traditional environment. That's what we call C3C, or rather the Health and Social Services Centers, CLLC in Quebec, and I was supposed to meet Julie Dernay and the various stakeholders because they were looking for a person who would accept to supervise the group of stakeholders. So I'm going to share with you those 2 experiences later on, and they're very different. You will have a chance to see this by yourself. And so it led me to change quite a great deal in my teaching approach, to question different of the modules and things I was teaching before. So, and if I have some time as well, I'll speak about some obstacles that we have to face in universities when we want to put or to set up some intersectoral programs and interdisciplinary programs. So this will lead also to a discussion on what I call complex thinking, complex thought, but also I'll be happy to speak about the challenges and also the joy of interdisciplinary work, because what we actually put forward in universities is, subsidized research, but that is to the detriment of some more passionate research projects. Very interesting. Thank you very much. I don't know whether we'll be able to cover everything.
But it's really interesting. Dr. Julien.
Well, Dr. Julien, I don't have to introduce you. Well, the question of training really came from this question of durability and sustainability for the organization. So we were self-sufficient for some years, so we were very happy with ourselves, and so was the population, and that was enough. But when some people came up and said, well, we'd like to see what you're doing, what is really social pediatrics in communities? Well, we tried then to go for a training through exposure in a way, which is something that we did with medical residents in pediatrics, but also social workers and legal workers and others. But we do not manage anymore because there are more and more people getting interested in social pediatrics, so to be exposed to it is not enough. And to be exposed, this exhibition was also done with the Montreal Children's Hospital and the St. Justine Foundation, and also the Rochester group. Jeffrey and Andy, who welcomed us in their place and came to help. So we had the first training course to exposure. To expose students, where during 1 month students are experiencing various community settings and challenges, with the hope that some years later this might lead to some kind of a fellowship in social pediatrics. And it's not yet achieved, but we wanted to go beyond the simple, what I call exposure training course, which is fine, definitely. But I think we're going to discuss about this question, and so we might be a bit provocative to start a discussion. I think we've gone beyond that stage, and I hope that the residents also will go beyond. And this part for us should be carried out before, upstream, in a more spontaneous way. So those students who are, interesting for us are those who have worked already in community settings, who have sometimes foreign experiences. So students who have innovated, and they would like to join this group of social innovators. There is a long road ahead of us, but this is really the type of students we're interested in. And this part, which I call the exposure part, should have been done a long time ago once you come to the level of residency, so that you can have more intense clinical residency with interdisciplinarity and to apply then in social pediatrics. So we have a module, a training modules that you can see. I think, I can't remember which number 2. Maybe for us it's a priority, this module, and with the help of new stakeholders such as Diego, Romain, and others, we are really here capturing the basic clinical knowledge that we want to use. Before that, it was done through exposure, but not in this way. So we are developing this approach, this part, and we have to find new technological methods to also distribute this throughout the movement, but also to other movements. The other part we're interested in training, and we've started to test it, and that's what you said earlier, are universities. As long as it will not be a more solid university cursus, even in theory, in social pediatrics, it's going to be hard. So what we want is to have an intersectoral training. And, when we speak about medicine, social rights, social law, and so 3 faculties together, 3 departments that could present a curriculum that would also have some stakeholders that would be much more socially minded and intersectoral. So various stakeholders who would learn to work together starting at the university level. It is a major stake, but it's one that is very dear to us. And since we are about to having a chair in this area, what we are going to support this with research. So this is a bit the situation that we find ourselves in today. And to conclude, I'm going to redefine social pediatrics in community, which is very different from what takes place in social pediatrics elsewhere. For instance, compared to Europe and the friends in Europe that have actually helped me also to develop the practical model of social pediatrics in community, what I've understood that in Europe it's really connected to public health. You know, early childhood, well, I can't remember how he said it, childhood help or support, but they are more, you know, concentrated on population and a lot of research, but it's a lot less a clinical practice as we do it here. Both are complementary, of course. We are different. We're different from the hospital's social pediatricians who will find themselves in different surroundings. They have to deal also with legal medicine as well. And so we find ourselves in a more integrating process between vulnerable children, between vulnerable families, what are their needs, the various health determinants, their rights, and how, as an intermediary mechanism, we're able to integrate these concepts within an action plan. And again, also an action plan integrated between the various institutions that do not really communicate, and we try to put them together around the table. And once we have achieved this, then you can have an action plan with all types of activities. And sometimes those activities can take place in the health services, in schools, in the hospitals, and the youth centers, but we are the engine or the integrating mechanism, and it requires a particular expertise that you do not find elsewhere. So this is how clear I can be in terms of defining social pediatrics in community, and we are based, of course, on the UN Convention on the Rights of the Child.
Yes, thank you very much. My experience from teaching social pediatrics stems from both starting with young students coming to medical school to postgraduate training in the School of Public Health. And as we talked about yesterday, my experience is about the same as was expressed by Andrew, for instance. The difference, the different approaches, the different notion, the different developmental stages that the students are in are very important. We discussed also after the session yesterday that we agree that students, when they come to medical school, they are very eager on learning how to treat people, how to help people, how to be involved in the real care of people and children, of course. But then they are destroyed in medical school, because then the focus is on something totally different. It's more clinical work, and it's patient and doctor-patient relationship. It's not so much to look at the social aspects or the community aspects or any other broader aspects than it is confined to the big hospital. They are destroyed by the teaching, they are destroyed by the hospitals. And then when they leave university as doctors, they come out in a reality that they don't recognize from the big hospitals. And if they are clever and recipient, which most of them are, after some time they realize that this is not real life. This is not what we learned in medical school. We need something else. And they are starting to look around. Where can I get more knowledge, more experience? Who can I talk to? Who can they who can I ask for help and assistance for this? And some of them then are happy enough to end up in or approach a School of Public Health. And since I then came from a university, a pediatric department at the university, to a School of Public Health, bringing with me my experiences with children, of course. I started immediately when I came to this School of Public Health also courses in social pediatrics. So, and then, since this happened to be a school that it is owned and run and paid by the 5 Nordic countries, by their governments, we take students from all these countries, we take teachers from the country, all these countries, and we bring them together for courses. And we also always mix different professions, like doctors and nurses and dentists and social workers and psychologists, veterinarians, whatever. They have a foot, or managers, whatever, they have a foot into health. And we're then focusing on child health. We bring all these good people together. And when they are very kind to the teachers, they say that about half what we learn at these courses come from you teachers, and the rest comes from when we are discussing with all the other people who are coming here. You can imagine that if there is a nurse from Finland, there is a manager from Sweden, there is a doctor from Norway, and there is a nurse from Iceland, for instance, coming together. They have similar problems with children's health and well-being, and they have different backpack, they have different experiences, and they have perhaps different solutions also. But then when they discuss, they stay there on campus for a fortnight or so, then discuss with each other. And it's a lovely experience for them and also for us teachers, because they learn something totally different from what they used to learn at university. And they not only do they learn in these courses, they also keep contact afterwards. And they can continue starting projects, and they can starting activities together, and they travel to each other. They visit each other privately or professionally. And sometimes things happen also. I've been attending a couple of marriages and weddings, and but that's beside the point. Anyway, this is something quite fantastic when you get these people who are experienced, but in various parts of it. But they're all focused on children's health and well-being, and they all come from different settings, but they all also have experiences, not only from the university, but they have been working in communities, in counties, on the state level, different levels, for 10, 15 years or so. Their mean age is something slightly above 40 when they decide to go to this kind of postgraduate training. And then if they like, they can continue to get the Master of Public Health, they can have Doctors of Public Health. I have had a number of nurses and doctors and psychologists and dentists who have finalized their doctoral thesis within child health. And that's an excellent product of that go back. Then they go back to their community, and then starting teaching and promoting the ideas that they learned at the School of Public Health. And we think that that's a very good thing to do, of course. But again, I would like to of course, to have a head start for these thinking already and in medical school. And whenever I have the opportunity, I try to talk to people in medical faculties how important it is to start these kind of activities, not wait until they are 40-odd years come to a School of Public Health, but to give them this insight and these visions already when they are in medical school. Thank you.
Dans mon travail depuis mai 2006 et avant.
In my work since 2006 and even before, in a non-official way, we see very clearly that there is a need to really answer the needs of children. Whether you are a physician or in the field of social work, you realize that children have a lot of needs that we have to meet. And in the US, it has been demonstrated that every time a child was going to see a doctor, a physician, there were one or two rights that were not respected, whether it was housing or social security, so all those toxic stresses. And in 1989, you have the UN Convention on the Rights of the Child. In 1991, it was ratified by Canada as well as many other countries. And then we started to get interested in that before 2006, of course, before I joined the foundation, but in the social pediatric centers. When I arrived, we had to develop tools that would go even further in terms of interventions. And so the legal aspect through mediation, for instance, has led to the fact that we have set up what we call the circle of the child to be able to meet the basic rights and needs of a child with the family and other stakeholders around the child, with the child. And then was very interested because I'm a lawyer and I live with a physician, so that's a natural alliance between health and law. Maybe some others had this type of let's say, relationship without necessarily being married, of course, but they've been also in the US. I haven't really looked elsewhere, but you have a lot of medical legal partnership for children that have been set up by Dr. Berries O'Common, who is a pediatrician that is maybe, you know, has as tall as Jeff. I can't remember, maybe he's 6 feet 6. I can't remember. But anyway, he's quite an impressing person, and so he has actually a lawyer in the hospital, and then the board of directors of the hospital has said, well, are you crazy? They're going to, you know, be after us for malpractice. So, yes, there will be automatic translation of the word she said in English, malpractice. He couldn't remember what it is in French. So malpractice, yes. And I was also interested in what was taking place there. And there was a training that was taking place at university level. And I said, oh, interesting, training at university level. And we hadn't really started to think about university training, you know, rather official between law and medicine. So we started looking at what is taking place. There are several universities in the US, and through my readings also I realized that in England as well, in Europe, you have several universities that actually provide training and curricula, including legal teaching in medical studies. And I realized that there are major stakes because both cultures, we've spoken about the culture of medicine and the culture of the legal world, well, the differences are quite major.
Of course, to merge the two, sometimes it's quite difficult. Maybe they've taught law to medical students, but sometimes the cultural divide is even greater. So they started to look at this, why this divide existed, and they realized that what they had forgotten, they were thinking about what to teach, to whom to teach, but they had forgotten why, the why. Why would you teach law in a medical faculty? And I'm wondering also, why do lawyers not get any courses on medicine? When we are a lawyer for a child, we do some mediation work, but there are experiments even since '58 in the US. That's a long time ago. There were a few projects that were carried out. They were abandoned afterwards, but those projects are carried out by faculties of medicine that integrate law courses. So they have disciplinary teams made up of lawyers and physicians. So this is more a kind of practical training and not theoretical training. So this is the challenge that we are facing today. We want to have even more intersection with other disciplines. We're talking about, we want to add social sciences, of course, the psychologists, and other kind of therapists. So it's already a great challenge to have that intersection between law and medicine. It's going to be even greater with social sciences. And some universities in Quebec are interested in with the idea.
Universities arose in the Middle Ages because of the sense that knowledge needed to be transmitted, that learning was something that was desirable, and that if you didn't have a mechanism to transmit knowledge, it would always remain the purview of a few. Think about the monks up in the hills with their books, right? And that you wouldn't better humanity. So, to me, universities are fundamentally about learners. And that leads me to two thoughts, which are that we accumulate knowledge in order to be able to, in the idea of universities, to better humanity. And yet, we recognize that there are things that are just out of our reach in terms of the betterment of humanity that we need to focus more attention on. And I think that community pediatrics has always been important, but I think that as health has evolved, that there are different epochs, there are different morbidities that are affecting children. Mm-hmm. And so if you look at, at the turn of the 20th century in the 1900s, the late 1800s, if you look at what was killing children, it was infectious diseases. And so people talk about a classic morbidity in pediatrics. Then people started to talk about a new morbidity in pediatrics, which is the recognition that we figured out ways to deal with those infectious diseases. Immunizations were part of the story, but sanitation actually was a much more important part of the story to get back to environment and community. Now we're living in an epoch where I believe what we have for kids is something called the millennial morbidities. And again, I go back to the fact that universities exist to address, to further knowledge and to further humanity. And the millennial morbidities are, I talk to our residents about them being as a dirty half dozen. They're the dirty half dozen. They're violence and child abuse, mental illness, injuries, obesity, teen pregnancy, and in a big bucket of things, inequities. So if universities exist to further knowledge and to help learners to address the most pressing needs of humanity, they need to be focused to some degree on those things for kids. And I come at it from a perspective of pediatrics, of healthcare training. But I recognize that that's a limiting perspective, and we talked yesterday about the needs for partnerships and training lots of different folks, and education and learning of lots of different folks to address these millennial morbidities. And I think it is very powerful to do that. It is very powerful to do that. There's a great, I'll quote from Harry Potter. There's a great dialogue in one of the Harry Potter books where Dumbledore, everyone know who Dumbledore is? Have people read Harry Potter? Where the children are asking Dumbledore, why he's not president. And he says, I'm more powerful than that. Because I teach the next generation of leaders. And that's what I think, and I talked a little bit about this yesterday, that's why I think this is so important, and I think connecting Gilles' work and the work of others here to young people and universities is so important, because the way that we're going to get more powerful, the way that we're going to address those terrible morbidities for kids is by bringing the next generation of leaders along to focus on those things. You know, I'm 47 now. My kids joke that I look pretty good for 47. Although my son Jack the other day thought I was celebrating my 57th birthday. And so he said I look really good for 57. But I think that young people younger than me are going to solve some of these issues. And there's youth that goes along with age. But, you know, there's this concept that, you know, if you take the most pressing problems that exist and you show them to young people, what they'll try and do is to figure out how to fix them. And, you know, things that some of my colleagues maybe will say are impossible to fix, they will figure out how to fix. And that's the point of universities. And that's the reason to connect with universities to do this kind of social and community pediatrics work. The last thing I'll say, provocatively, as we engage in more dialogue about this, is that in my role with the American Academy of Pediatrics, we've worked with 70 pediatric residency training programs affiliated with universities in both the United States and Canada over the course of the last 8 years. And there's a lot that we know about what really works in this kind of training. And I'm hoping that as part of the panel or in conversation with you afterwards, we can talk more about that.
Can we talk more about the obstacles? Because you referred to, Madame Mongeau referred to obstacles. Maybe some of you are skeptics about the capacity of creating these integrated knowledge or integrated programs. Madame Trudel talked about schism between medicine and law. Mr. Kohler said, Dr. Kohler said that universities and big hospitals destroyed this attempt to open programs. How would you define the real problems? Madame Mongeau, voulez-vous commencer?
Alors, c'est ça, je vous disais que dans la même journée,
As I was saying, the same day I visited a CSSS. We used to call them a CLSC. And I will tell you about the 15 first minutes of that visit. I arrived there, and there was an officer at the entrance who said we had to disinfect our hands. That's what I did. And then I went to the waiting room, and I saw that there was a queue. I was not in a hospital. I was in what was a health center. And on the floor, there were arrows showing us where was the queue. And I saw a sign on the wall that said, "We don't tolerate violent behavior, violent words, and also wait for your turn before you go to the receptionist." So when it was my turn, I gave my name without saying I was a university professor. I said I wanted to meet a member of the staff. They said, "Yes, we'll tell her you're here. Sit down, please." So there was the waiting room. It was, as we see it very often, everybody was seated vertically. It was not a circle. We were all in a row. Nobody was talking to another person waiting there. So I felt a bit stressed. I was thinking if I were a parent with my child, I would feel a lot of stress. And then somebody came to get me and bring me to a room where she had to enter a code to unlock the door, that's where they would meet with families in those offices. And that social worker was a charming person. I don't want to underestimate their work, but I only want to tell you how the physical environment has a great importance and can have an influence on the relationship you have with the families. And later on at supper with my children, I was talking about that, and I was thinking that message, that sign saying we will not tolerate any violent behavior, it's telling people that maybe some people would get violent, some people maybe somebody will try to rob because the doors are locked. The staff has to open the door with a code. So it means you're not, this is our place, this is not your place. In fact, you're not welcome, and please do not disturb anybody. That's the message. The same day, I went to somewhere else, another office for children with problems. I was in it was not a waiting room, but there was a room, and there were two mothers, a mother with a baby, and the other one. They were talking, they were standing. They were not, they were really having a conversation. One was from what I heard, she was a sex worker, and the receptionist asked, have you eaten anything? She said no, and then she was told there are fruits, there's fruit, there are muffins if you want to eat. And I was listening to the conversation between the two mothers. The mother was talking about her spouse, and then as she involves me in the conversation, and she offered me something to eat. She said, are you hungry? There's fruit, there are muffins. And then later on, Julie came to get me. I went to the meeting. But what really struck me with this is this. In that situation, I could see how the AED was an extension of their home. The mothers themselves were deciding what were the codes, how they would enter into a relationship with people. And I was the stranger who was brought in the conversation. And I thought, well, I wanted to explain my children what is a proximity intervention. I will tell them, I will give them that example, and they will understand immediately what I call a proximity intervention. Yes, that's very interesting. It's related to the different from the bureaucratic environment and a very innovative environment, very interesting experiment. So we want to remove silos in universities. Maybe you should talk about that also. Well, I would say that to have cross-sectoral projects, interdisciplinary projects, we have to have a global vision. We have to think collectively. But as Dr. Steinmetz was saying yesterday, we got lost along the way. And now we're being too simplistic, maybe. So we have to be interested in a non-reductionist knowledge, but universities are divided in different departments, law, medicine, psychology, humanities. So this is really a compartmentalized environment. And at UQAM, we have service to communities, and that's one of their concerns. They want to have interconnectedness. For example, when we set up that training, at first we wanted to offer it also only to the AED interveners, and they convinced us to offer it to some other people, and that it would be a traveling training. So you would go from one center to the other in the neighborhood. That's one obstacle. Another obstacle is to integrate cross-disciplinarity, where we all have our own reasoning. We tend to defend our own professional territory, each on our side. Somebody said I was very much interested in multidisciplinarity, but I think we're all a bit handicapped because we're not trained according to that dimension. We're really from one discipline, and we have to change our way of thinking. And really, at the start of our training, we have to get exposed to that, because we get into very bad habits, and then it's hard to go back on that. I would like to come back to the professional barrier. It is very present. I've witnessed it in the CLSCs as a doctor. Those centers were set up to merge the social and health dimensions, but that will never happen. I worked in several such CLSCs and the Côte des Neiges at the end, and I remember very clearly, I was the only one present in the clinic. And I realized I was very aware of the fact that it was impossible for me to solve very complicated social problems. So I had to only keep to my work as a doctor. You know, there were a few respiratory infections to treat, but we were talking about the new social morbidities, what we call the millennium morbidities. 30 years ago, we would say the new social morbidities. Nobody knew what to do with that, but I was stuck with that, and we have several pediatricians here who've lived with that. Through that era, I was trying to go to a social worker. That's why I didn't like social workers at the start. They would say, "Well, you're a doctor. You don't have anything to do with this, with social work." I would say, "Yes, but we share the same clinic. Could we talk to each other?" It was hard. Same thing with the nurses. Nurses would say, when I wanted to get interested in child development, they would say, "Well, you're on my turf. The doctor should only treat sickness or illnesses." So it was a bit frustrating. That's why I got out of there, and I wanted to have this bottom-up approach to get to have the knowledge about the social issues. The knowledge, in fact, is at the bottom. But all of a sudden, we had all kinds of public health programs that were imposed on us. They would say, here is this very nice program that they wanted to implement in the CLSCs. It never worked, and it was very costly. So what we created, in fact, was a base of knowledge that we want to disseminate. It is the local knowledge. It's very powerful when we're talking about the toxic stress or morbidities, and then go up to the universities. And that's a great obstacle, because universities are not used to being told what to do, and it's really their ego. So that's a real obstacle these days. But I'm optimistic, because there's a real movement taking that is emerging. There's also a major public interest. That's why the Quignolet works very well, the campaign around Christmas. And because we have this knowledge base that is logical for the public. And this will bring a paradigm shift as young students will do. I've met them here. Leonard says it well. We destroy the reason why they decided to become a physician. I entirely agree. When I meet with first year students, I tell them, keep the spark that brought you to the faculty, because they will try to extinguish that spark of interest and in you to become a doctor. In the hospital, they don't understand. What's the difference between a pediatrician, a social pediatrician, and a social worker? And the question was asked yesterday. She's here. We'll talk about that later on. And that shows you exactly what's happening. When it comes from the bottom, it's simply not credible. Nobody believes it. That's what we have to change.
Microphone is out. Anybody wants to comment before we go to the people in the room briefly about what you heard? Madame Bennett, Monsieur Dr. Kazarovski.
Thank you. Just a couple of comments about the obstacles to the implementation of curricula in the university. You gave some good bottom-up examples. And for myself, I think we're working with an evidence-based medical system, and we're working with medical models. And we all know about the medical models, top-down hierarchy, and having this equality, equity between us, equal partners at the table, equal voices, to be looking at the societal problem. It's not just child abuse and neglect that's the domain of the child protection pediatricians or whatever you call them. But the evidence, this is a real issue because it's bandied around so freely that this is the top gold standard in the Cochrane trials, and it's beautiful to have these double-blind randomized controlled trials. It's not going to happen in the millenniums with the mental health, the child maltreatment, these social situations, unless we look outside the fields in anthropology, social science, research. But it's so hard to find out, and we need the data. What is the problem? What's the scope of the problem? How are we going to put prevention programs in? How are we going to monitor these things? So there's a real challenge when we come to the evidence, and I think we have to look at different ways. It was mentioned yesterday briefly about what are the other ways that we can look at the problem besides this evidence, this knowledge. It can come from different systems. It can come from all these multi-partners outside the Faculty of Medicine perspectives. The challenges are in this field, and the name to me is very important. If I'm going to go to my department chair and try to develop a social pediatric model, now I'm not wondering, what am I to do in a hospital? Can I say I'm developing community social pediatrics? These are sort of side discussions I can have on. But these principles, I have to convince people. I have to convince them with some good arguments. It would be great to have all the data to be able to say we need to implement this. So we have to convince the people in the decision-making, in the power, that this is important. And we are going through a very optimistic phase. I think there's reverberations globally with the importance of social pediatrics and encompassing. What has been very good for me is to be working with Jeff Goldhagen on this. I mentioned earlier the American Academy of Pediatrics endorsed first fellowship. Now, somebody else on the panel might know of other fellowships, but I believe it's the world's first, as it's advertised, in community and societal. And I asked him, why societal? Why not social? And I haven't been involved in all the discussions about the naming, and I'd be interested to hear some of that in this panel about this social. But he's saying societal because he's putting as overarching children's rights, social accountability, social justice, ethics, health equity, all of those. And I'm sure these were in the philosophies already, but it's verbalized. And that's the overarching piece. So I guess he had to put in his grant proposal to get the $2.5 million from the University of, from the US government, should I say. He's got this to develop this curriculum that will go online, open university, and I think it will be really important to incorporate the work you've done, Dr. Julien. You've got the modules already in French. I would encourage you to, all the work that you've done, if you can get translated into French and join the systems. But for me, that has been I think we as champions moving this forward, we have to keep ourselves alive, and that's been something developing the curriculum. with a group of like-minded people, and then to be integrating that into the daily experience with my residents. And I have one right here I'm meeting after a couple of years, and the last time we met, we were just talking about these very issues, right? You come to learn about bruises and all the awful things that is what people think is the regular medical model. I just say one more thing. In the US, the subspeciality of child protection was just recognized by the American Board of Pediatrics a couple of years ago. It's now called Child Abuse Pediatrics. So these all child abuse pediatricians being with this new fellowship. It's not a name that I particularly like. It's for all kinds of reasons. But I would love to see social pediatrics, social community, but becoming a fellowship.
Okay.
And it needs the champions.
Moi, quelque chose que je rajouterais aussi que je vois qui est un
And
des
something that I
obstacles
also
majeurs,
see as
possiblement, il y a
a
plein de
major
solutions,
obstacle, of
mais,
course, there are
ça
many
serait la
reasons, but there would
flexibilité
be
des programmes
also the
maintenant.
flexibility of
Les
programs
exigences
and
scolaires
curricula.
royales, c'est comme
You know,
une liste
the
incroyable.
requirements now
Donc, je
are
pense
really
que
an
ça fait en sorte
incredible
que là, il
list.
faut faire des stages
And so you have to do, you know,
de
pediatrics,
néonatologie, des stages
training,
aux soins
neonatality,
Il faut
and
faire
all
le
kinds
temps de
of
spécialité,
different
il faut faire- Donc, je pense que
internships
ça,
and
c'est
training
un des
courses.
freins qui
You
fait
have
que
to have many
malheureusement, des fois, c'est
specialties. And I
difficile,
think this is kind of an
d'inclure la
obstacle
pédiatrie
that prevent us sometimes to
dans le
integrate
curriculum,
social
mais,
pediatrics in our
tu sais, je crois
curricula.
qu'il y a des solutions aussi, puis
But
que
of
c'est
course,
vraiment important
there are
de travailler
solutions, and I think what is
sur le point que je
important
voulais mentionner,
is really to work on that.
à ajouter.
So this is
Puis
the point I
également,
wanted
des
to
fois, les
add.
cultures d'institution,
And
donc,
also,
plus c'est
the
gros,
bigger the
plus c'est difficile à
institution, the
changer.
more difficult it is to change the culture.
We talked about the great benefit of working with universities, but hardly anyone, to your point, would call universities nimble or quick to make change. They exist as institutions, and I was made a list when Gilles asked about the audience in the room this morning, and we had health, psychology, social sciences, law, research, education, music, politics, all in the same room. And if that were a university, the discussion would go like, who's going to pay for the coffee? Whose chairman is going to speak first? Universities are not set up to be interdisciplinary and collaborative in many ways. They're big institutions that are not nimble. And so we have not solved this problem. I think that in Rochester, we feel like we've gotten a lot further than where we were a decade ago in terms of training people in various disciplines, but we still train largely health professionals. We've gotten out of just being pediatrics, and we train people in internal medicine, and we train people in psychology, and we train people who are in nursing. We've sometimes dabbled in training in nutrition and social work, but we've never trained people in the School of Education. We've never trained people in music. I think it's hard, and we've been doing it a long time. It's hard to break down those barriers to get around those cultures. I wanted to say, though, that I think one really important solution for both the interdisciplinary barriers and for what we talked about in terms of doctors losing their perspective on why they wanted to be doctors is to get out into the community. When I look at the difference in terms of collaboration by being out at a community center versus how that would proceed at a university, I think a really key thing is to get out of the university into the community, focused on kids, and to put kids first, and that getting out into the community takes away the politics and the academics and the research dollars and all of the stuff that exists at the university and potentially allows for those kinds of collaboration to happen. And you're illustrative of that.
I don't think it's very useful to kind of force people from different professions to come together and say, now you have to learn together. I think it's much better, as you say, go and see where they are working together, or where they really have to work together to reach their objective. Mm-hmm. And just to give it a very short example, we have in Sweden something called a Well Baby Clinics, has been developed over the last 70 years or so. Everybody is bringing their child to that center for vaccinations, for advice, for examinations, for dental health advice, and mental health advice, and everything. Everything. Now, the next step of that is to create something we call family centers, where the mothers still, or the parents, still bring their child, but at the same time, they can also consult a social worker there. They have an open preschool, so the older children can come there. If the mother is pregnant, there is a maternal health center as well. And then, when you talk to these people, and they are working in the same area, different rooms, but in the same area, it's no difficult at all to get them to train together, because they realize we don't know exactly what you are doing, but we want to know, and it's very easy to arrange training courses or whatever you like for them together.